It gives me great happiness to be able to introduce our speaker for tonight, which is Mr. Michael Waldram, who's a consultant orthopedic hand surgeon based in Birmingham. And he's been a consultant since 1983, so it's roughly 39 years, and he's due to be retiring this year. So he has lots of experience working in the NHS, but also volunteering abroad in Sierra Leone. And he's collaborated in the past with a charity called Research Africa, which is well known, and with the BSSH, working with a multidisciplinary team of consultant surgeons, anaesthetists, even registrars, whilst working to develop the first reconstructive surgical unit in Sierra Leone. So we're very excited to hear more about his experiences. And our first question is just to open the floor to find out more about your overseas experience to date.
Well, thanks very much, Denise and Haneen, and hello, everyone. It's a pleasure to be talking about any work of the BSSH overseas. My own personal story winds back a long time from when I was at medical school. We did second MB, which was like 2 years before you went on the wards doing clinical work. And I was at the Royal Free Hospital in London. And after second MB, I was quite interested in overseas work in Africa. And I went out to Kenya to a mission hospital. And at that stage, I hadn't done any clinical work ever. And I saw surgery for the first time. I saw cesarean sections. And I had never been in an operating theatre. Up to that point, I'd only done basic science. So I was quite sort of gobsmacked by it all and decided that I wanted to go back to Africa when I did clinical work. So at the end of my clinical training at medical school, our training was 5 years, I went back to a mission hospital in Liberia in West Africa. And I basically got to do everything. I was doing operating with an American surgeon, delivering babies, cesarean sections, and again, it was just amazing. A lot of pediatrics, and sadly, quite a few little ones who died of cerebral malaria, which was quite something to see when you were just barely qualified. So that kind of stayed in my mind all those years. And then during my training in orthopedics, I started off in general surgery and then gravitated to orthopedics. And then I soon found out that I really enjoyed and liked hand surgery. I did a fellowship in America, in Kentucky, for a year, and then worked in Birmingham, and where I've enjoyed my consultant work very much. So it's always been niggling in the back of my mind that maybe I'd like to go back to help out in Africa. And then I've seen a number of colleagues who perhaps towards the end of their careers have gone and done altruistic work around the world, where they've worked on mercy ships or gone and operated in disaster areas or whatever, particularly plastic surgical colleagues. And I felt a bit envious of them. So I listened to an overseas presentation at one of the BSSH scientific meetings, and I told Steve Hodgson afterwards that I'd be interested in going along on a mission to observe, because that's where I felt most comfortable. I'd just like to watch. And he contacted me after about 6 months and said, Mike, you're leading the next team to Sierra Leone. So I thought, oh, golly gosh. And so that was 2017. So I got a team together, mainly colleagues who I knew in Birmingham. And we went out for about 10 days, and it was absolutely fantastic. The team really gelled. We had trainees and consultant anaesthetists and anaesthetic assistant and a therapist. And we went to McKinney Hospital, where there are no surgeons regularly who live there or work there. There was a physician. And so they had visiting teams come from around Europe. And the BSSH got involved with that in 2012 and have sent a number of teams out, probably 2 to 3 per year, and was obviously put on hold during Ebola and put on hold obviously from COVID. So it was very much a trip to do rather than just teach. And so that in itself was pretty scary. But then after 2017, we took out another team, which I led in 2019. So that's been my experience. And I've just thoroughly enjoyed the involvement, both with colleagues, trainees, and more recently, there have been 2 plastic surgeons who qualified in Ghana who've now started working at McKinney. So that's the most exciting thing.
Well, thank you
so much for that, Mr. Waldram. Whilst you were out in Sierra Leone, what did you specifically do out there? And do you have any interesting cases that you particularly learned from whilst you were out there?
Well, yeah, if I may screen share, then I'll show you some of the things. So this is, we called it, can you see that okay?
Yes.
Surgery where consent is a thumbprint, because a lot of the patients can't write their name, so they just give the thumbprint. I'm not sure I could tell whether their thumbprint was them or not if they did it again, but there we go. So this was the team that we took out, and I'm just going to tell you who these people were so you know. Are you seeing that picture okay?
Yes.
So we took out, I told everyone, bring your own scrubs and your surgical shoes. And we kind of left them all there and we didn't bring them back by mistake. Ha ha. So that was my idea of the NHS's contribution to it. And so we built up our scrub in the doctor's quarters, which is where this is. And this is Nico, who's an anaesthetic assistant, Rajiv Joshi, who's a consultant plastic surgeon, hand surgeon with me in Birmingham. This is one of our trainees. This was an ODP who's now working in Australia. Chris Baldwin from Sheffield, myself. Shiv Singh was consultant anaesthetist, and Joel was our hand therapist. So that was the team. There was 8 of us. And there was a little bit of pre-screening before we arrived, but basically the hospital advertises that a team is coming, and then you get clinics, which are quite heavy the first 2 days of the week that you're there. And we obviously wanted to try and limit our work to things that we could deal with, but also upper limb conditions. And so we always had 2 consultants, orthopedics, there's me and Chris in plastics, and someone recording. And we saw the problems and decided, could we help this patient by surgery? So I instituted a thing we called Doc 1, which meant that you knew what the diagnosis was, that was D. O was that you knew what the operation was that you could do for it. C meant low comorbidity. Most of the patients were young and fit. And 1 means that you could do it in one straightforward operation. So complex things that the patient had had for 10 years, you're not going to sort out with a week's visit. So the team found this quite helpful, just to try and sort of work out which patients we would help and which we'd like to, but we couldn't. And obviously we got referred things that were really way outside of either own expertise or even our own knowledge. But most of it should have been upper limb conditions. So here we are operating. This patient was under general anaesthetic. There's Chris operating and me assisting. And we tried to sort of set up a scrub board where they'd keep sort of count of all the things that we take for granted, like the scrub count. They weren't very disciplined at, so we had to kind of tighten up on it and get them to do a WHO check. And they knew that in principle, but they weren't doing it in practice. So things that you and I do every day, we suddenly found we had to sort of re-emphasize. We did do some regional blocks. In those days, we weren't doing so much Wallant, but Wallant is another option. And we found that the general standard of the theatre nurses was really high. and they've obviously seen and helped lots of different teams do different things. They have other teams visit, like for cleft palate surgery and that sort of thing, foot surgery. So they've dealt with many different types of operation. So the wards here are really high standard of cleanliness. You see all the mosquito nets tied up during the day. And whenever you went on the wards, there was always a nurse by your side who wanted to, if you said, I want to see the post-op patients, they'd go around, they'd take notes, they'd give you gloves for each patient to put on, they'd give you hand gel to squirt in your hands, and they're really, really on it in terms of the nursing standards, and we were very, very impressed with that. Obviously, very good training in the past. And something that we've kind of lost in our UK practice, I think, is just having a nurse there and working with them. And often the nurses would come to theatre and say, we can't read this, what does it say in the notes? And so they really were taking great care to try and do what we wanted. So here's a little boy who had a burn injury on his thumb with a scar contracture, and his name was Michael. He was age 3. And this is Chris Baldwin from Sheffield, and Chris operated on him and did a nice sedplasty to open up his web space again. And here Joel has made a nice hand splint, which he wore for about 6 weeks afterwards. This was a girl who came in, she'd had club foot. She was a teenager, she was age 13, and she literally crawled in. She couldn't walk on her feet. And she'd had very little input in her life. And once we gave her some of the crayons and books that we brought out to give to the children, she had never seen a colouring book before. So we managed to contact a foot surgery team who dealt with club feet, who were coming to the hospital from Germany 2 weeks after us, and we debrided the ulcers on her feet where she'd been sort of walking on the side of her feet. And they later then did an osteotomy and correction with a pin, and she did very well. So that sort of cooperation is quite amazing. You'd think, oh, well, you know, we can't do anything here. But in fact, with a little bit of cooperation, she was literally brought in by an American charity worker who said he would pay for anything that needed to be done. And suddenly you're presented with these sort of decisions, and what do we do? So with something like that, what we did was we all just got all the facts, got the x-rays, and then sat round after dinner in the evening and discussed what was the right way and the best way to take it forward. So that was Memunatu, who was age 15. We did some teaching when we were out there, some basic things like ATLS, treatment of burn injuries, resuscitation, what do you do if someone's having a fit, how to put a plaster on, these sort of things. But the staff were absolutely riveted. They really enjoyed it, especially when we did sort of play acting of someone collapsing, and then how would you turn them over and all of this sort of thing. So it was a great team. That was the 2017 visit. And we got some T-shirts made with Sierra Leone 2017. So that's the sort of flavour of it all.
Thank you. It's really nice pictures, and also really interesting to hear more about the project and how different people were involved and what you all were able to do together. You mentioned about the German team and an American charity involved, and I just wanted to find out, how did you go about coordinating the different teams that are involved in providing the care? How did you guys communicate together and keep each other informed? And was that difficult to do?
Yeah, because it was, you know, we were way outside our comfort zone, and you had kind of no idea of like who was coming and could you hand anything on. It's a little bit different now, because in this hospital we now have 2 surgeons who work there. They do a job share, so there's kind of 1 surgeon for the week, and they're plastic surgeons. So that sort of coordination should be a lot better now. But I had no idea where the other teams were coming from, what they were capable of. And so I had to just probe around and find out whilst I was there what I could get, what was possible, what was feasible. Whilst we were there 2017 and again 2019, we did a complete inventory of all the theatre instruments and everything. And as you can imagine, lots of goodwill, people taking out stuff, but an awful lot of clutter that was kind of irrelevant, totally unsuitable, outdated. And I reckoned over half of the metalware and stuff that had been taken out there was just completely inappropriate and not really usable. So I did a complete inventory and we made some recommendations about what should go and what should be kept, and things like a little battery driven K-wire driver we thought would be useful. Lots of complicated plating and so on is really, it's a risky environment to do that kind of orthopedic surgery. So, there were kits for nailing femurs and so on, and that wasn't going to work in that kind of theatre environment. So coordinating to one team to another, not easy at all. Coordinating BSSH team to the next BSSH team, a lot easier. Communication within our own team, really good. We found that at the end of every day, we needed a sort of, how can I put it, like a catharsis of everything we'd seen.
Yeah.
To get it off our minds, talk about it. And some of the stuff, we didn't know what it was, so we had to look on the internet and sort of resources. Sometimes we contacted people back home via WhatsApp or email and said, we've never seen this. What is this? People who had like terrible jaw tumors and things like that, they're nothing to do with hand surgery, but you see them and you think, how can we help this person? And of course you can't. And that was the most difficult thing, was turning stuff away that it was quite florid, because you see pathology so much more advanced because people have not had access to medical facilities. So what you have to try and do is be really ruthless with yourselves and say, well, let's be realistic. What can we do? What can we achieve? So an example, I'm not boring you, am I?
No, I was actually going to add and just say, you mentioned about the Doc 1, like the schema that you had to help you decide what things you could manage. That's actually, I haven't heard it before, and I thought that was a really helpful way to kind of see what things could be treated, like you say, once, and not necessarily need to be repeated or not necessarily be staged. But was that something that you picked up whilst working in Sierra Leone, or was it something that you taken from working in the UK? To put into practice?
No, it's just the way my mind works. I just thought, okay, I've got this wonderful team. And I could see where we were vulnerable, would be taking on something where we might make a bigger problem out of a bad problem. We could make it worse. So I thought, how Mike, how could you say you'd lie awake at night thinking, what could you? And it's just the way that's the fun of leading a team, is to try and get the best out of everyone. And it doesn't need to come leadership from the top. Often the trainees would say something and you think, gosh, yeah, that's really important too. And so everyone's contributing. And so sometimes when you're in a surgical situation where you're under a bit of stress, you're a bit vulnerable, you find that the team really gels. I don't know whether you found that over COVID, but there are times where you support each other because it's a bit of a struggle, and there've probably been times in your training when you felt that, and it was that kind of feeling. So that's where I just thought of it, the Doc 1. But an example of how you had to think out of the box was we found, although we're saying, no, we just want hand and upper limb conditions, we would see occasional brachial plexus and things like that, but then people would send down an iPhone picture of a Siamese twin or something like that, and you'd say, no, I'm afraid we can't. This is not our, our domain. And of course, some of these people have just shopped around. If they hear there's a doctor in town, a particular visiting surgeon, they'll they'll try anything in terms of, bringing someone along or a relative along, or sending a picture in or something like that. But we did find that we were asked to see and treat tropical ulcers around the lower ankle and foot. This is the sort of tropical ulcer, I think it was a patient in their 30s, so quite young, long-term ulcer on the side of the foot, doesn't heal. Now, my colleague, Dominic Power, nerve and upper limb surgeon in Birmingham, had visited before and told me, he said, Mike, I think these are colonated with Pseudomonas because you can smell it.
Oh,
and so they did some grafting when they were out there, and he said all our grafts failed. So he said, I'm sure it's Pseudomonas. You need to treat them with acetic acid. So when we started being shown these patients, we thought, well, okay, so let's treat with acetic acid. And we knew about this coming our way before we went out, but obviously you can't take acetic acid in your hand luggage or anything like that. So we got our house cook to get some vinegar from the local supermarket, and we diluted it up, which is terribly important. And the patient had this put on topically 3 times a day for 3 days before we did the graft. And the graft take rate that Dom had was about 20%, which is not very good. Our graft take rate went up to 80%. So you didn't need a microbiologist's report to say this was Pseudomonas. You could smell that sweetly, sickly smell. And so just by thinking outside the box and thinking, well, how can we achieve this within our week? I thought, well, if we get these all in early and we do these, we can graft them on our last 2 days. And then we did WhatsApp follow-up ward rounds after we left. So that's the sort of approach that you don't, it doesn't really apply in the UK, but you have to think outside the box.
That's so interesting, Mr. Waldram. Similar to this sort of case, did you find whilst you were out in Sierra Leone that there were things that helped you or has changed your practice whilst you are in the UK? Were there experiences that you encountered that have sort of changed the way you practice at the moment?
I'm not sure about change the way you practice, but certainly change the way you think. And everyone said that, because when they came back, and I say everyone from sort of my level to consultant level to trainee level to junior consultant level, everyone said that they really appreciated the many fantastic things that we have in the health service, staff, facilities, cleanliness, drugs, probably not the ability to keep patients in beds for so long, and maybe, as we found, the nursing standards were probably higher out there, but just the many things that we take for granted, particularly in a theatre environment, so anesthesia, sterility, WHO checks, all these sort of things. We all said, and we had sort of debrief meetings after we returned, and everyone was saying exactly the same. Aren't we lucky? Aren't we lucky? And it's sometimes not till you go to an environment where you see that a lot of things that you're very familiar with that should be there, that aren't there, that you suddenly begin to realize the importance. So then you have to think, well, how can I as a doctor try and improve things here? It might be teaching, might be training, it might be getting some charity monies to provide something. But normally it's investing in the people rather than just things.
Yeah, thank you. You mentioned about the different people who make up the team having different views on their experiences. And I know from the report on the 2017 project, there was a registrar who was present. And I was just interested to know, especially from your early experiences, having shaped your interest in this area, what kind of things did the registrar member of your team get involved in? And what were they able to kind of help with, whether that be observing or helping with teaching or providing their own experience to help shape what was being done in Sierra Leone?
Everything in the same way that they would in a UK practice. So if it's operating, it's supervised operating, and there's no reason that they can't be involved in that. If it's teaching, they're probably closer to the age of the people they're teaching than I am, and so they're probably better at it than I am. And if it's helping in an outpatients, then they can see the same patients we're seeing, but then they might be able to help take a dressing down, and then we could look at it together. And the most important thing is that they must be involved in seeing the decision-making process, and their input, much like in a WHO check, is as important as anyone else's. So sometimes a training doctor can pick up nuances better than a senior doctor because they're younger, they've got a fresh mind, and so I believe that their opinion is vital. I believe that their contribution to the team is essential, and the learning process is no different in principle than it would be in a UK setting to a lower income resource setting. I think to go without trainees would be a great mistake in my view. And there's no question of them sort of practicing on people in that kind of setup that they wouldn't do in the UK. The supervision should be there to the same degree. But the opportunities to help are there for everyone to learn. And I feel that the day we stop learning, then we should retire. But because we always learn, don't we? Patients teach us new things, or we see something we've not encountered before, so we ask a colleague, what do you think? And that we're always learning from the process. Sometimes things don't go entirely as we expect, but there's nearly always a lesson to be learned from it.
Thank you so much for that, Mr. Waldram. One last question. I know COVID and Ebola has had some restrictions on going back to Sierra Leone, but in your retirement years, have you got any plans to go back at all?
Definitely. We want to restart because one of the plastic surgeons came to the IFSSH meeting in London, which was fantastic. And he went to Manchester in the week before. So I think that it's really interesting that the COVID levels are very low out there. And it's interesting to think why, because they're basically an unvaccinated population. And yet COVID is so low. Why is it? And whether it's the ventilation, because they're largely in outdoor life and open windows and all of that. Homes are very open. But yes, I think we're at the stage of making plans. We're probably going to do a scoping visit first. There's a therapy input from Pascal Smith, who wants to do a therapy training course at McKinney. And now we've got surgeons there, it's going to be less doing and more teaching the principles in their own setting. Now that's quite exciting when you look at what we started off with, because we went from a situation where we had a lovely hospital but no surgeons. And now if we've got some Sierra Leonean surgeons there, then the important thing is to try and encourage and help them. We've been doing Zooms, discussing 2 or 3 cases right since, well, for the last year. And that's been pretty helpful, I think, for them. And we have on the Zoom only people that have been out to McKinney, so they know what it's like out there. So they're not just talking pie in the sky, they know the difficulties they face. So, for instance, there was a terrible fire disaster where an oil tanker exploded in Freetown this year, and these 2 plastic surgeons just got inundated with. They had lots of teams jumping in from USA and all over the place, and Médecins Sans Frontières and so on. but then they've now gone. So they've now got all these patients with sort of chronic contracture from burn injuries, and we were trying to link them up to some burn surgeons in the UK, because obviously we're not burn surgeons, we're hand surgeons. But I think that we're at the stage of scoping out and restarting visits. Yeah, hopefully in a similar, but kind of in some ways a new, exciting way.
And have you, been using WhatsApp to help with that follow-up with the patients that are, because I saw some.
Well, we used WhatsApp after our visits for ward rounds. And of course, you've got very experienced nurses, so they're doing dressings, but they're also very experienced at sort of knowing when things are not improving. And so we did WhatsApp ward rounds of all our dressings and so on. That carried on for some weeks afterwards, after we left. And the WhatsApp now, I don't like too much of just a picture, what do I do? I like
the story.
I guess I'm a bit more old fashioned. I like a history, an examination or whatever. So where it's been helpful is taking a video of like a child of what they can do using their hands. So your colleague Haneen in Sheffield, Chris Baldwin, there was a child with a sort of club hand type picture, and we were discussing about whether it should be released now, the baby was only 1, or whether you should wait. And he said, well, he'd really like to see a video. So I said, well, that's not a problem. So, within 3 days we had a video, and that came through WhatsApp. We had another patient discussed who had a terrible tumor on the forearm. And we as a group thought it looked like a sarcoma, and the patient's relatives, he was a 12-year-old boy, wanted limb sparing surgery because they'd read about it. And so we got an opinion from the bone tumor unit in Birmingham within a week, showing them all the scans and everything that had been done. And we told them that we thought probably an above elbow amputation was the right treatment. Unfortunately, the parents didn't like that and took the child off to Ghana. But I think actually we did our job, because we gave the right opinion of a high caliber sort of opinion from local surgeons. And I don't think you could ask for more than that. So that sort of thing, WhatsApp can assist, but it shouldn't be just on its own a picture. Can you help?
Thank you so much, Mr. Waldram, and thank you so much for all your insightful experiences. I think it's been really interesting. Denise and I have been interviewing a number of different consultants, and it seems like your experiences are all so different, but ultimately have learned so many things that are so relatable to your day-to-day practice. And we hope that one day Denise and I will start going out ourselves. So thank you so much for your time.
No, it's a pleasure.